Okay. So thank you everyone for joining us for the first in our series of HPV Lunch and Learns. So this session will focus on an overview of HPV and general trends. So our host moderator for the session is Sarah Chavez and Eric Adjay. Um, so Sarah will be acting as our moderator for the session, and Eric and Sarah are part of the leadership of the Illinois Cancer Partnership Prevention Committee. So Sarah is the chair and Eric is the co-chair. So I will stop sharing my screen and hand it over to Sarah.
Hi, yes, thank you everyone for attending today. So during the course of our work group, Eric and I lead the Illinois Cancer Partnership Prevention Subcommittee Work Group. It's basically a group of stakeholders throughout Illinois who are interested in any sort of cancer prevention topics. So that can include everything from smoking cessation to HPV vaccination. In our work group activities, we were talking about ways that we could incorporate what our group discusses and bring that to a broader audience, and also hopefully invite more members to join our work group. So if anyone is interested after this meeting in being a part of our work group activities, please feel free to reach out to myself or Eric or Linda, and we can definitely get you involved. This is our first webinar series, but we're hoping it's the first of many. We think this is a really effective way of reaching members from across the state and bringing topics that are interesting, but maybe are difficult to find information about. So we want to cover in today's session, we'll be covering basically an overview of HPV and looking at the trends here in our state. So our first speaker that we're going to have is Dr. Suzanne White. She is a regional medical director employed by Merck, and Dr. White has over 25 years of clinical leadership experience at Detroit Medical Center and Wayne State University, where she served as a professor of emergency medicine and pediatrics and the chief medical academic officer. Dr. White graduated from Wayne State University and completed her residency in emergency medicine at Wayne State. And she also completed 2 fellowships at Wayne State University and Drexel University. She served as the chief medical advisor for the city of Detroit, overseeing health department programs such as immunizations, reproductive health, emergency preparedness, and communicable diseases. So today, Dr. White will be helping to introduce the topic by giving us an overview of HPV trends.
Thank you so much, Sarah. It's just really an honor to be here with other folks on this panel, such esteemed colleagues, and I'm just really grateful for the opportunity to talk about this important topic, especially in light of the fact that this is Cervical Cancer Awareness and Cervical Health Awareness Month. So it's certainly timely to really be discussing HPV. And I really just wanted to open up the session with some information around HPV-associated cancers and diseases and the opportunities that we have in terms of vaccination rates. So most of us are aware that HPV is a very common infection in the United States. It's also very transmissible, and I think most are aware that this is the leading cause of cervical cancer. What I see is a general lack of awareness around the other types of cancer that are also caused by HPV. And some of this really has come to light over the past several years. A lot of the information was somewhat buried in the pandemic. And really what we've learned, though, from some interesting studies that have gone back, for example, and tested actual tumor tissue from tumor banks and tumor registries for the presence of HPV, we have learned that HPV is a leading cause of cancer for each of these types that I've listed here on this slide. So not only is cervical cancer important to keep in mind, but be aware that across both genders, we see HPV as a leading contributor to other types of cancer as well. And then when we look at trends, so this is an important, also recently published look at where we see cervical cancer rates going nationally and where we see other types of HPV attributable cancers going. And what we see here is this crossover where, you know, we still see very high cervical cancer rates, unfortunately, although there has been somewhat of a downward trend. But what we see happening in addition to that is this increase in oropharyngeal and other head and neck cancers that are attributable to HPV, predominantly affecting men, as you can see in this slide. And I think that this is a very impactful slide because what it shows us is that each year, if we look at the current vaccine that we have against HPV in the United States, Gardasil 9, and we look at those 7 serotypes that are in the vaccine that are known to cause cancer that we can protect against. We have the opportunity to now be able to prevent over 31,000 cases of cancer each year that are attributable to HPV. And this really only includes estimates around actual cancer cases. It doesn't include, of course, precancerous lesions that certainly cause a lot of morbidity as well for individuals and life-altering circumstances as well. So those numbers are much, much higher. So this slide is just to show us really that there was a change, and this change occurred in June of 2020. As I mentioned, it was kind of all of these pieces of information coming together at around the same time in terms of trends and in terms of tumor analysis, and really leading to an expanded indication to vaccinate to prevent cancer. So now what you see is a gender neutral recommendation, ages 9 to 45, to prevent cancer and precancerous lesions and genital warts. But the big addition here that happened in June 2020 is the addition of oropharyngeal and other head and neck cancers as an FDA-approved indication and an accelerated indication to vaccinate. So certainly vaccination is a key step in prevention. We have a huge opportunity and a huge call to action around that. What I would hope to do is just show you a few slides. I don't want to spend too much time on the statistics here because I know we'll be covering a lot of data from my other colleagues who are on the call today. But just to show you that we do see tremendous variability across the US when we look at, for example, cervical cancer screening. And I'm showing this one simply because you can see how Illinois, certainly there are opportunities here with regard to cervical cancer screening when we look at other states as well. Not that all states are doing great by any means, but we certainly see patchy screening going on. And we also see significant variation in the rates of cervical cancers that are newly diagnosed. And I'm sure we'll hear more about that as well. Similarly, with regard to oropharyngeal cancer, this I think is important to just keep in mind, again, because this rate is going up at about 2.7% per year. And we see tremendous hotspots with, you know, most of the new oropharyngeal cancer cases occurring in the Midwest and the Southeast. So definitely some geographic patterns here with regard to actual disease occurrence. And I think we have to also think about how we're doing with regard to vaccination rates as well in very general terms. I know you're going to hear a lot of state-specific information, but if we look in general, and here we're really looking at the NIS teen study, starting with adolescents. This is a very large survey, as you know, that's carried out annually. And what we see here is that we've always seen this lag when we compare a single dose of vaccine of Gardasil 9 as compared to, say, Tdap or meningococcal vaccinations that are given at exactly the same age. So HPV vaccination does lag behind and still continues to do so. We do see geographic variability here. Again, when we break that down, we break that previous graph down across the US geographically. You can see where we have significant variability. And this is with regard to just one dose, a minimum of one dose being given in terms of adolescents. So much, much worse when we look at completion rates. So series completion, of course, is much lower, not even close to our 80% healthy 2030 people goals. So this is much lower whether we look at 13 years as a mark of completion or whether we take that up to 17 years, we still have dismal rates. We see, again, geographic variation when we look at those numbers and break down those bar graphs. And here you can get a sense for how that plays out in different locales across the United States. This is really very new information, and taking that same study, so the NIS teen study, and a retrospective analysis was carried out to look at urbanicity, which is really kind of a new way to look at this, not just looking at the state itself, but looking at rurality and urbanicity. And what we see is that with regard to adolescent vaccination against HPV, there is a significant lowering with regard to rurality. And we see that gap play out here. Even when we control for poverty level, we see that gap persist. So very important to keep in mind that it's not just the state level information we need to look at, but also we need to be looking a little bit deeper potentially at the numbers. And then finally, I just want to kind of conclude here by showing what tremendous opportunity we have in the 19 to 26-year-old age group. These are our young adults. These are individuals for whom universal catch-up is recommended. And you can see the opportunity we have where only about half of females and only about 25% of males have received even one dose of HPV vaccine in these age groups. And then when we take this up to our mid-adult population, again, these are individuals for whom the vaccine is indicated. We see essentially an unvaccinated group, particularly men, very, very low numbers. And in women, the numbers are also very low as well. So a lot of opportunity, and I would just say for each of us, it's a call to action to remember the A's, the 5 A's around improving vaccination rates. And think about these presentations today that you're seeing. What can we do individually? It's our call to action, whether it's access, whether it's issues around affordability or awareness. We each have a role in making sure that we are improving these rates and protecting every life against cancer. Since I did mention the vaccine, I will just scroll very quickly. Of course, there's a lot of information about Gardasil 9 in terms of safety, tolerability, and efficacy. This is all in the product information at the Merck website. So I'm not going to go through that all today, but I would refer you to that information as well. So with that, Eric and Sarah, I hope that I did stay on track in terms of timing. And thank you again for the opportunity. And again, this is information that I think makes us all step back and say, what could we be doing to take advantage of this opportunity?
Yes, thank you so much. We thought it would be helpful for everyone here on the call to hear that national perspective. And then as we start discussing sort of actions that we can all take here locally in Illinois, we have that perspective of what works across the country and sort of where the areas for growth and improvement exist. We're trying to keep it on a positive note about what can we do to correct these problems. Okay, so our next speaker is Dr. Leslie Carnahan, and she is a research assistant professor at UIC School of Public Health and a research scientist at the University of Illinois Cancer Center. Her work is specifically focused on understanding and addressing cancer health inequities in screening, diagnosis, and treatment through engaging in community-driven research using both quantitative and qualitative methods. And she also serves as a public health consultant and evaluator for a number of cancer prevention and health promotion programs in Illinois. So today, Leslie will be speaking on the HPV-related burden report and some more specific information regarding the HPV burden here in Illinois.
Thank you so much for the introduction. And thank you, Dr. White. Again, your presentation is just such a great segue. And I will make the disclaimer, all three of us that are presenting today, we have that same slide that Dr. White showed that shows the intersection of oropharyngeal cancer surpassing cervical cancer. But I think as I'm presenting a lot of data today, and again, like Sarah mentioned, this presentation is based off of some work that we did with the Comprehensive Cancer Control Program to prepare. There's 2 reports about HPV-associated cancers in Illinois, and I believe Linda or Elise will put those reports in the chat. But yeah, I think going back to, I'm going to be sharing a lot of data, mostly related to Illinois, also showing some national comparisons, but I'll minimize what Dr. White already presented. But again, I think just really pressing on, I know when we've talked a lot about HPV-associated cancers, the trend has been to focus a lot on cervical cancer, but we need to really expand our views on that. And today I'll also share with you some policy insights in Illinois. We've had some really exciting legislation that was passed in 2022 around HPV vaccination. And I'll also talk about some policy opportunities as well. So again, I'll just go ahead and get started. Okay, so again, thinking about HPV-associated cancers, and again, let's remember all of those cancers that are related to HPV. And these are data from 2015 to 2019 from the CDC Cancer Viz. And there's over 236,000 cases per year. Again, like we already learned about, among females, cervical cancer is responsible for about half of those HPV-associated cancer cases, and among men, oropharyngeal really leads the way, being responsible for most of HPV-associated cancers in the United States. So looking at our first slide here on rates of HPV-associated cancer in Illinois, by sex, we can see, again, oropharyngeal really leads the way in terms of the rates of new cancer cases. And then breaking that down by gender, males are a bulk of those cases. But, not to minimize, anal and rectal cancer is also an HPV-associated cancer that is prevalent in Illinois as well. And again, oropharyngeal and cervical are really leading the way in terms of HPV-associated cancers. And so, like Dr. White was sharing information about looking at place matters. So in Illinois, we see our rates, but if we dig down a little bit deeper, we see variation based on urbanicity, right? So how rural versus how urban you are. And for the oropharyngeal among males and females, and cervical cancer, that's what this graph is showing. So we can see again, across the state, in general, oropharyngeal cancers among males has the highest rates, generally speaking. But we can see in our rural parts of our state, those have the highest rates of diagnosis of oropharyngeal among males, as well as cervical cancer among females. So again, thinking about what does that mean for us working in different parts of the state? Of course, in Chicago, we still want to pay attention to this, but collectively as a state, we might want to, turn our focus a little bit to our rural populations to understand how we can address HPV-associated cancers. And so this slide here is now bringing in mortality rates as well. And we can see this is broken down by gender, and we have data for both Illinois and the United States. Typically speaking, for oral cavity and pharynx. And I just want to make the statement, when you're looking at HPV-associated cancers, sometimes the classifications of the cancer sites, so you can see these data present oral cavity and pharynx, and these are how these data are available. So we try to streamline that where possible, just in case anyone was wondering that. But for, again, cervical cancer, women in Illinois have a little bit lower incidence rate than in the US overall, but for oral cavity and pharynx, we have higher rates in our state compared to the US overall. And again, we know that oral cavity and pharynx cancer is more common among men. And so this is, sorry, there's too many things popping up on my screen and I couldn't see the title of this slide here. Okay, so now again, right, so we were looking at just some rates that were really basic to the entire population of the state. But when we break this down by race and ethnicity, we do start to see differences. So for oral pharyngeal cancer, in the state of Illinois, white non-Hispanic males tend to have higher rates compared to males of other races and ethnicities. And this holds true as well for females. White non-Hispanic females in the state have higher rates of oral pharyngeal cancer. However, thinking about this from a health equity lens, and there are health equity issues around mortality, especially for Black non-Hispanic population. So despite having lower incidence rates, they do have a higher mortality rate. And we know that a lot of that is related to the structural and social determinants of health, and typically around healthcare access issues, and so on. So now moving into, and thank you for bearing with me. I know this is a lot of data. And again, I just want to refer you to these reports that are posted on IDPH's website, and Linda will, again, have shared those in the chat, and that has a lot of narrative around the reports. And again, for people working in the state, you'll be able to hopefully find yourself and see yourself, whether you're working in a rural part of the state or in Chicago, in this report. But when we look at cervical cancer incidence in Illinois, unlike the oral pharyngeal cancers, Hispanic and Black non-Hispanic women tend to have higher rates of cervical cancer incidence compared to white and Asian Pacific Islander women in our state. And they have a much higher than the Illinois average overall. And unfortunately, but I think, you know, we can say not surprisingly, these health inequities persist among cervical cancer. Mortality rates among Black and non-Hispanic females in our state. So in our state, Black non-Hispanic women have higher rates, both than Black women in the US overall, and much higher rates than white women in both Illinois and in the United States. And excuse me, and the difference among Hispanic women, actually, sorry, this is an error. In our state, the rate is almost the same compared to white women, but nationally, Hispanic women have typically higher rates of mortality compared to white women. Okay. So I won't spend too much time on this slide because Dr. White has already covered this, but again, this slide is in here because this information is just so important, right? And thinking about, when we're thinking about HPV, I know we got to think outside of cervical cancer because we can see oral pharyngeal cancer is on the rise, and there's a lot of opportunities, especially as we've expanded how we think about our vaccination efforts. So again, Dr. White was talking about this in terms of HPV vaccination. We know that HPV vaccination can prevent up to about 90% of cancers caused by HPV. And we think about the 6 most common cancers that are related to HPV. This has a lot of potential for saving a lot of lives, which is phenomenal. So I think, right, when we think about how we talk to clients, how we talk to patients, right? It's not just one type of cancer that this could be preventing, it's multiple. So these data here, so now thinking again about HPV vaccination, and now we're thinking about HPV vaccination in the state of Illinois. These data are actually more recent than the data that were included in the HPV report because we recently had access to the 2021 Teen VaxView data set. So like Dr. White mentioned, we have a 2030 healthy people goal of an 80% vaccination rate. And we can see on the left-hand side, we have some of these vaccinations that are required, right, by school enrollment. So Tdap, that had, it's way above the 80%. But then we start looking at HPV vaccinations, and we have this data, fortunately, differentiated by sex. When we look at the vaccination rate for initiation, which we'll call someone having at least having one dose of the series, among females in Illinois, we're at about 77%. So, right, we want to get that as close to 100 as possible, but it's nearing that Healthy People 2030 goal in the state. Among males, vaccination initiation for HPV, for the HPV vaccine is also not doing too bad, right? Still room for improvement. But then when we look at the actual up-to-date rate, so what we would consider someone to be fully protected, essentially, we can see that the rates start to drop. And they're, are further away from our Healthy People 2030 goal. So again, thinking about, right, it's great to get someone in the door to start their vaccination, but how do you get them to come back to complete the series? So thinking about strategies related to that. But again, right, we know that our population is not a monolith. People have access to and different norms around vaccination. So when we start looking, and I apologize, we were not able, we got the Teen VaxView 2021 data set very recently, and it's a little bit of a complicated data set, so we weren't able to provide an updated view on breaking down vaccination by these different sociodemographic and geography placed variables. So these data are from 2015 to 2019. So they may be a little bit different from the 2021 data set, but we're assuming that the trends will probably remain the same. So when we look at urbanicity, these are the blue bars on the top. So living in a non-MSA, really that just means living in a rural population. Vaccination rates much lower. Right, we have variation by race and ethnicity. And we have differences in terms of poverty level. And then we have differences, very stark differences, which is, again, probably not surprising, related to insurance status, right? So if you don't have insurance, your opportunities to engage in the healthcare system probably aren't going to center around HPV vaccination. So we can see that why those rates are most likely extremely very low. All right, so I wanted to focus on, now, right, I presented you with a lot of data, probably too much data, and also right around HPV vaccination rates. So I think there are, right, looking into the future, what can we do? We know that Big P policy is always a great way to go in terms of influencing health outcomes for populations. And so as a part of this report, we started looking into what is happening in the legislative front around HPV requirements. And we were really looking at HPV vaccination requirements for school entry. Because some states have started to take action on that. So in the US, about 27 states have enacted legislation for HPV vaccination, and 18 states have introduced legislation. So I think that's telling us that our policymakers are quite receptive to bringing this to the floor to talk. And Illinois is an awesome state, and we have some great public health policy leaders. And so we're one of 20 states who have enacted legislation to improve education, awareness, and access around the HPV vaccination. However, in our state, we do not have any HPV vaccination requirements for school entry. Rhode Island is the only state that has HPV vaccination requirements for public school among both boys and girls. And Virginia and the District of Columbia does have this requirement, but unless this has been updated since we were doing our research, it's only required for girls. So I think, again, we can think about in our state, if this is something that we want to pursue on a legislative front, let's make sure that we include everyone and not just girls in this legislation. And I'm pulling this up on my phone because I don't have this here on the slides. What's really exciting in the state of Illinois, passed in 2022, we have Illinois Senate Bill 3682, and this is called the Reducing Cervical Cancer and Saving Lives Act. So this has some language about providing people with language that they can understand about their cervical, about their pap smear test. But one interesting thing about this piece of legislation, and this in the state of Illinois is going to pilot a program among clients of the Illinois Breast and Cervical Cancer Program to pilot HPV vaccination among recipients of this program. And in the state of Illinois, I know roughly 10,000 women benefit from the Illinois Breast and Cervical Cancer Program. So I think this is going to provide a great opportunity for increasing our vaccination rates in the state. And this pilot is, per the legislation, is set to be launched by July 1st, 2024. So stay tuned, because I think there's going to be a lot of action around that. All right, so I'm almost done. I just have a couple more slides here. And just talking about, thinking how do we increase the uptake of the HPV vaccination. So I'm going to state some things that, I know I'm preaching to the choir here, but when we are implementing our interventions and strategies, there's a lot of information and resources about evidence-based practices and interventions. We've talked a lot about policy efforts, right? We can do things at the clinical level, we can do things in our communities, but we do know that big P policy makes a huge impact. And so, how can we ensure that what's happening in Chicago is happening in the rest of the state and vice versa? And when we think about HPV vaccination efforts, working in public health and other settings, we're often, we can't do it all. So, do we need to focus on specific populations in the state? I think we see a lot of opportunity in rural parts of the state, and especially around males. So thinking about, with limited resources, how can we have the biggest impact? And again, I'm not going to belabor this slide, but when we think about policy opportunities, I know I was talking a lot about the big P legislative policy, but we can also think about policy in terms of, what are we doing in our clinical spaces? What are our clinical policies? What types of things do we have in place for our providers to be equipped to be able to do this kind of work? So, what can we do in our communities and our clinical settings? And then these slides will be shared with you, so you can look at these policy opportunities to increase vaccination uptake. Like I said, not all policy has to be that big P legislation policy. There's lots of different things that we can think about. So I know, again, in the state of Illinois, our immunization registry, and someone please correct me if I'm wrong, but HPV vaccination is currently not right now a required reportable vaccination. So if it does become a required reportable vaccination, I'm guessing that's going to change practices a little bit. In our communities, can we bring vaccinations to where people are versus having people come to us for the vaccination? But again, for the sake of time, you'll have these slides and you can see if this helps to generate any ideas of what you might be able to do in your communities. And finally, and this is geared especially for people who work in clinical settings and do provide direct patient care. We know, especially in light of COVID-19, there's really been a lot of conversations around vaccine hesitancies. But I think it's really important to acknowledge, right? Of course, we want people to get vaccinated, but it's also really important to identify and to understand folks, you know, there are legitimate safety concerns. Sometimes, you know, providers, there are barriers around hesitancy because some providers still don't recommend the HPV vaccination for males, for example. There's trust issues. And some people just think, you know, I'm not going to get cancer. It's not going to happen to me, so I don't need it. But we do know from our current literature that clinician recommendation continues to be the #1 reason that parents decide to vaccinate their children. And so again, provided some information about some resources, especially for people who work in clinical settings who want to learn more about how to speak with their clients about the HPV vaccine. We have a lot of resources here for you. And again, if you have any questions, feel free to contact me, or you can also contact Linda as a part of this report was produced with IDPH. So thank you so much.
And thank you, Leslie. We actually do have a question or a hand raised in the chat. I don't know, Sherry, would you like to come off mute? And you can go ahead and either type it into the chat, or you can just speak if that's easier.
Yeah, people can enter their questions either in the chat box, or there is also a Q&A panel.
Yes, and if anybody's not quite as familiar with WebEx, just look in the bottom right-hand corner. You'll see the little chat box there. So feel free to be entering your questions in there, and we can and we will have some time at the very end too, if you'd like to just speak your questions directly. Okay, so our last speaker today is Aubrey Thielen. She joined the American Cancer Society in August of 2021, and Aubrey has public health policy and advocacy experience at the federal, state, and local levels in topics as wide-ranging as violence, urban planning, and paid leave. She has worked hard to connect these issues to chronic disease and cancer through partnership over the last 7 years of her career in both Louisiana and Illinois. And she is very passionate about her career in public health as a way to influence equitable cancer prevention and care in the communities in which we live, work, play, and learn. Aubrey is a graduate from Tulane University with her Master of Public Health in 2015, and she currently lives in Chicago with her dog Stella. So thank you, Aubrey, and I will turn it over to you.
Thank you so much, Sarah. I'm excited to get started. I know Doctors White and Carnahan did such a great job outlining a lot of the background data, so I'll try and gloss over some things, but highlight some really important pieces while going through my presentation. I think that my presentation is particularly associated with action. So if you've been hearing all this data and thinking, what do I do about it though? We have some options here. So I'm going to go ahead and share my screen and we'll get started. So we should be seeing the PowerPoint that I have here, and it should be the regular. Okay, perfect. I see head nods. So yes, we'll get started then. So I'm going to be talking about the Illinois Action Plan to Eliminate Vaccine Preventable Cancers. It's really focused on that prevention piece, the primary prevention piece of vaccination. So as we go through, I will refer to it as the plan because that's quite a long name, just for housekeeping purposes. But we'll talk about two different viruses that we're focusing on specifically because they have vaccinations. I'll lightly touch on hepatitis B because that's the second one, but the first one is HPV. And really, this is an important topic because the World Health Organization estimates that 15% of human cancers worldwide may be attributed to viruses. And so this is a great opportunity, again, to focus on that primary prevention specifically. So let's get into it. So got some real high level information about HPV, human papillomavirus. Here's a lovely electron microscopy picture of HPV specifically. But I think that Dr. White went over this a lot of the types of HPV that the vaccine prevents, and that overall, some of these have symptoms, some of them don't, including genital warts, which is something that we can kind of look as a proximate measure for HPV in some cases. And I will talk about a certain success story involving that as well. But yes, thinking about when we can start vaccinating, we start at age 9. It can go up to 45, but it is covered by preventative care until 26 by insurance. So great opportunity to just get that taken care of before people age out of that preventative care piece specifically. So as we're going through talking about HPV and cancer, we've seen this figure before. I'm going to address it, but I do want to just highlight a few other things that really we're looking at when we're looking at Illinois and the rates. The HPV vaccination, as we've talked about in the previous presentations, as much as HPV is extremely common and it can clear on its own, we're really looking at those that don't clear and that can result in cancer, those specific types of the 100+ types of HPV. And that in Illinois, we're hovering around 62% with that Teen VaxView data, the NIS survey data, really looking at that it's 62% for HPV vaccination, self-reported for those teens 13 to 17, while Tdap is over 90%. So it's something that as we examine what we can affect, there's this gap, and we see that gap, and we want to make sure that we're addressing it. This specific figure we've talked about as well, and the different types of cancers that HPV can cause as well. But really that inflection point in 2009, looking at cervical cancer, which has been decreasing for the last 50 years due to really successful pap smear campaigns, but is kind of leveling off. And then also having that oropharyngeal with males specifically increasing. We've touched on this. It's really something that we want to focus on, and something that when we're talking about HPV, originally we used to focus just on women and girls getting the vaccine. Now we're focusing on both men and women, boys and girls. And this is really the data that backs up that and making sure that we do that. Just one last note about this increase that we're seeing in this inflection point here is that from 1984 to 2004, the CDC's National Program of Cancer Registries and the NCI's SEER registries reported a 50% decrease in HPV negative oropharyngeal cancers, but a 225% increase in HPV positive cases. So we're really looking at this as like, this is that gap, that specific gap. So I want to touch just briefly on HBV or hepatitis B, just because it's part of the plan, a really prescient type of things that hopefully will just sneak into your mind with the rest of this HPV talk. Just that a lot of HBV, hepatitis B virus, is the leading cause of liver cancer. Up to 50% of liver cancers are caused by hepatitis B, and I'll talk about how common it is in the next slide. But a lot of us are vaccinated for hepatitis B, especially if you were born after 1997 or generally the early 90s across the United States. But there's that huge gap as well of people who are over 30 who may not be vaccinated for hepatitis B. And last thing I'll just note is treatments are available for hepatitis B, but no cure exists. It can clear on its own, similar to human papillomavirus, but vaccination is essential if we're trying to prevent it. So brief touch again on the landscape of hepatitis B. It's extremely common, unfortunately. And what's more concerning about it, beyond the 2.2 million individuals in the United States that are living with chronic hepatitis B, is that 2/3 of them are unaware of their status, that they have chronic hepatitis B. And that's the piece that can really cause liver cancer. That chronic piece doesn't clear on its own. And I just wanted to highlight, because we will talk just so briefly about how we can affect this. There are some special populations that we want to really think about with that. A lot of foreign-born people did not get that advantage of the infant immunization schedule, so they didn't get that hepatitis B vaccine before arriving in the United States, as well as Asian Americans are predominantly affected. There are a couple of different reasons that I won't get into because of this presentation, but they only make up 6% of the total population in the US, while they also are 58% of Americans living with chronic hepatitis. And then people over 30, I've already addressed this. There's that little data point there that proves, again, people over 30 really looking at your status if you're vaccinated for hepatitis B. And then people who are, their habits or their employment may put them at risk. So that's IV drug users, those occupational hazards, whether that's sex work or healthcare work. Those are just examples. And that's just due to the transmission, which is blood and semen. So let's talk about what we can do now. So we have this opportunity here. We're really seeing, again, this is probably my last piece of data, or last pieces of figures in the presentation, that we're seeing on the left, the mortality, the 5-year mortality rate change for most common cancers in Illinois, and the 5-year incidence on the right. And we see these two things that we've been talking about: oropharyngeal cancer, or oral cavity and pharynx, which you can see towards the bottom with those red rising rates for both, as well as liver and bile duct. So that's that hepatitis B point. And I do want to just say, this plan that we've created is something that focuses on elimination. And often in public health, we don't have that necessarily hopeful feeling about elimination here in most types of things that we do, but there is significant progress and success that we've seen with other in other areas of the world, specifically Australia. So Australia has focused on cervical cancer first with their comprehensive cancer programs and really focusing on screening. And then in 2007 added HPV vaccination and heavily worked on that over the last about 15 years now. And so after they've implemented a lot of this heavy focus on cervical cancer screening as well as HPV vaccination, including catch up to 26, they've seen the prevalence of those specific types of HPV infections drop by a factor of 10, which is impressive, including herd immunity in people who are not vaccinated for HPV. And then the prevalence of those anogenital warts, again, that kind of proximate measure potentially, they've seen substantially drop in female and heterosexual males. And then the last thing that I'll focus on is that they've seen these cervical precancerous abnormalities drop by 41% and nationally in women aged 20 to 24 years. So these are the people who are in that catch-up range getting those HPV vaccinations. And so this is a really hopeful story, I think, that shows that as a result of this data, that for those of us that have cervixes, might be really exciting to think that for them specifically in 2017 moved from every 3-year screening to every 5 years, and that's data-based. And that's they expect that this trend is just going to continue. So let's talk briefly about the plan. The Illinois Action Plan to Eliminate Vaccine Preventable Cancers. Who is guiding it? It's the Illinois HPV Advisory. We'll talk about that in a moment, how you can join, how you can get updates, those kind of things. Often can be described as the Illinois HPV Roundtable. I am the leader of that, so I'm really excited to be presenting on the plan specifically. But it started development in 2019 through IDPH, lovely, and ACS, American Cancer Society, as well as the Illinois Public Health Institute. And you can see there was a wide range, a lot of people engaged to see kind of what are the priorities, what are we talking about, what's the landscape, and then what can we do to solve some of the problems that were identified. It was published in March of 2022 and is updated yearly. So we're coming up on that update, which is something that's definitely on my list. And that it complements the state's comprehensive cancer control program and plan. There's no conflict there. It's something that we all can work on together. And again, that goal of elimination. It's the first in the nation to have this plan that is focused on elimination. And we're really excited about that as a prospect because there is that success that we've seen in other areas of the world. So what are the objectives? What are the actions? As I go through here, I think this is a really usable table for people as I'm just going to highlight one example from each action, but I've also included the people who can take those actions, those targets. So as I go through this, I would love if you could, think this is me, this is what I do in my personal or professional life that I can do personally to take an action. And just one last note about these actions, we've spent a lot of time disseminating, including this webinar, the plan over the last year or so. And so as we go forward as the Illinois HPV advisory, we're really looking to prioritize the so many actions that are under each individual category. And so if you want to be part of that, see what is feasible, what's short-term, what's long-term, those kind of things, it's a great opportunity for you to join. So we'll just run through these really quick. You can view this online as well, and I'll put that joining link in the chat once we're taking questions. But first is improving data collection and reporting. We can't really know where we're going if we don't know where we are currently. And I believe it was Dr. Carnahan who mentioned that there is a gap of knowing who is getting HPV vaccinations in the state because it's not required for those who are on private insurance to report. Providers are not required to do so. And so there's lots of different things that we could do if we improve that data and collection and reporting by allowing us to analyze by social determinants of health, allow people to really view that at a more granular level and impact specific communities that are perhaps not getting those vaccines at the right times. Next is improved partner coordination and program support. Again, I think that anyone could participate in this, but really looking at how perhaps this is just one action of the many, but maybe making sure that you're engaging with the comprehensive cancer control programs throughout the grant cycle, not just at the beginning and the end of that, making sure that you're really engaging on these priorities. We've talked a little bit about advocating for policy improvements. Thank you, Dr. Carnahan. So I won't get too deeply into that, but yes, just to refer back to that first action category is improving that data collection and reporting. We need to make sure that providers are actually reporting all HPV vaccinations that are happening. That is required in other states around us, like Dr. Carnahan highlighted. So it's something that is doable and it's something that we can work on, and we hope that we can get providers to engage with us and also be champions on that issue. This is one of many, so that we can advocate for. Then I'm going to just quickly focus on the HPV vaccination rates among adolescents. This is something, if you're clinical, this is a great opportunity for you to really impact this action. Examples of this are using your EHR to prompt and remind your physicians, your healthcare providers to give the HPV vaccination if people are not up to date in eye care. This is starting at age 9, which is a whole toolkit that you can access on the National HPV Roundtable's website. This is having provider reports to show who's doing it really well so that they can help other people who are not doing as well in those rates in your clinics. So many different options. And if you're looking to have something that you really like to focus on, in the coming year or so, ACS, the American Cancer Society, is always working with clinical partners on this, can elaborate more, and I can connect you with anyone that might be in your area that could be helpful for that. Similar to hepatitis B, just brief touch on this, again, very clinically focused, but I chose one example of an action that is more focused on that local health department level, really making sure that you're promoting HPV vaccination among adults, focusing on the specific populations I outlined earlier, whether that's sex workers or healthcare workers or the Asian population, if that's someone you serve. Then the last two actions here, there are only 7 total, or categories of actions, suppose, is to educate new vaccinators. Whether you're a vaccinator yourself or you work for a university, a college, any type of, whether you're mentoring, this is a great opportunity for you to partner with our coalition, partner with specific partners to make sure that you are promoting how important these vaccinations are in the appropriate age group and catch-up vaccines. And then the last piece is promoting digital innovations and cultivating youth leaders. I think sometimes in public health, we aren't always on the cutting edge of digital innovations or marketing, and that's okay, but we do need to focus on that, making sure that we're reaching the populations that are using social media. It's only going to become a bigger part of our lives, and to segment potentially down to zip code or age or demographics. And so it's definitely something we're focusing on. So what can you do? How other things beyond, if you noted what that action that you're going to take in those examples, you can also join the Illinois HPV advisory. Like I said, I'll drop the link in the chat once I'm done speaking. And we meet bi-monthly to discuss the current topics and guide the plan. And then you can also commit to that one action, like I mentioned. You can view the plan at that link. I'll also send that out. Or you can contact me directly to share the link, to share the plan on your website, or engage more deeply in other ways. So this is just an outline, very, very brief, of those specific actions that we just discussed. And so I know we're running a little low on time, so I'll definitely open it up to make sure that Sarah can make sure that we've got, and the moderators can make sure that we've got some time to answer questions. But I'll stop sharing my screen.
Yes, thank you. So I think the main takeaway just from questions and from our presentations is like, well, what can we do? And that was kind of our thinking behind planning this series of webinars, was to first introduce what we currently know, provide those up-to-date data pieces that I think a lot of us are looking for, just so that we fully understand the scope of the challenges, and then to transition into looking at the how these HPV related cancers affect different specific populations. So that will be the next seminar that we'll have and that will be on Wednesday, January 25th. And then the third session will be on a Tuesday, just in case that's better for clinical schedules and everything. And that will be actually delving into some of these strategies for actually engaging with patients directly. So we're going to try to leave you with tools and some resources that we can all hopefully implement across our state.
Yeah, so there's only one question. I think we have 2 or 3 minutes, so you have to answer it very quick. Marianne did ask, what does a cancer prevention program and screening look like in the community other than education? So any one of you can give it a try really quick.
Well, I know from our perspective at Siteman, we're really interested in bringing community members to the table on these screening initiatives. In many cases, you have to go to where the people are and you have to meet them in places that they're comfortable with, because you're talking about very uncomfortable topics. So, bringing these cancer education, but also screening opportunities to individuals. And that's why the Illinois the plan that we have to actually engage with the breast and cervical cancer program is so exciting. It's making this accessible. It's making it easy. It's making it more, more available to people at where they're already going. So I think that really, for me, that's one of the keys. It's not expecting everybody to come to you, but to be willing to go to them to help them get the resources that they need.
And that's also in the state of Illinois, we've had some really promising movement around legislation around community health workers. So I think too, that's another great example. Trusted community leaders around health are out there, making sure that they are equipped to talk about HPV vaccination is another great way to bring it to the community for sure.
And I would just add as well, as you mentioned, Sarah, the kind of difficult conversations. I think how we are framing those conversations also is focusing a lot more on cancer prevention rather than sexually transmitted disease, really making that a routine recommendation, a very strong recommendation, not calling it out specifically as an STD or STI is another possible action. And I just wanted to make one quick other comment that I really loved Aubrey's presentation, and I think an exciting update that is related to some of the information she shared is that when we just looked at the Illinois landscape, we found that most commercial plans and Medicaid managed care are covering HPV in that mid-adult space. So the 27 to 45 is generally very well covered, and I think that will help us a lot as well to expand that protection into those age groups where we know when we look, we still find HPV still peaking and going up in those age groups. So just wanted to point that out as well.
All right, so it's 2 o'clock now. So in the interest of everybody's time, we are going to end here. So thank you very much for all the panelists, and we hope to see you in 2 weeks. So I hope everyone joins.
Yes, thank you all for
Thank
joining.
you so much.
Thank you.